Hello, good evening, and good day to all of you. I'm happy to be back with Dr. Lavy. How are you feeling, Dr. Lavy?
Great, thank you. Thank you for having me back.
Yes, we are very excited to have you back. So, thank you already for joining us once again. It's been a while, but I'm very, very happy that you've decided to support our Stronger Together initiative. And of course, you have brought the topic again on surrogacy. Thank you so much for that. And welcome, everyone. It's good to see you, of course, right here. And just let me briefly tell you how everything is going to look like. So, of course, we will start with Dr. Levy Lavi's presentation. And after that, as always, it will be time for your questions. So all you need to do is just type in all the questions that you have in the chat section. And of course, Dr. Levy will be, I'm sure, more than happy to answer it for you. So don't miss that opportunity and go ahead and type those in. And I just want to mention that, of course, Stronger Together, this is the second edition. We are focusing on treatment after failed attempts. So, of course, we are again here to support you, to educate you, to provide you answers, and of course, insight from top fertility experts. And of course, I also want to thank to all ambassadors and partners. You can see them right here. As always, without the support of ambassadors and partners, this initiative, it wouldn't be possible. So huge thanks for their constant support as well. And today, as I've mentioned, we definitely have an interesting, also sometimes very difficult topic. So I'm very, very happy that you have brought this to us again. It is surrogacy as an option for patients after IVF failed cycles. There are some case studies here included as well in Dr. Levy's presentation. So that's going to be very, very interesting, I'm sure. And I just want to mention that Dr. Gad Lavy, he is from New England. Sorry, he's the founder and director of New England Fertility, located in Stamford, USA. So, Dr. Lavy, I am very happy that you have decided to join us once again. I am very interested to find out what you're going to talk about as well. And well, are you ready to start with your presentation?
Absolutely.
Happy to hear this. And of course, here's the presentation. And go ahead.
Great. Thank you, Carolyn, for the introduction. So, as Carolyn already mentioned, I'm the medical director of the New England Fertility Institute. We're located in Stamford, Connecticut. I've been here for many years, over 20 years. And we've sort of picked this topic together, and because I think it's something that comes up actually rather frequently. And over the years, our clinic that basically is started as a general fertility clinic is focusing more and more on what we call third-party reproduction. One aspect of that being surrogacy. It's always been my interest, my passion, and we sort of created the infrastructure and all the regulatory things that are required for that. And the topic that we picked today is sort of maybe one aspect of surrogacy. And what I'd like to do is sort of give you sort of a quick overview of surrogacy, what it is, who needs it, how it's done, and maybe then go directly to a couple of cases that I chose, maybe just to demonstrate this particular part of surrogacy. So what is surrogacy? I mean, basically, we are talking about two types of surrogacy, but specifically what we do and is what we call gestational surrogacy. And gestational surrogacy is basically the woman, the surrogate, carries a pregnancy that is not genetically connected to her. So it's basically not her eggs, and this is in contrast to traditional surrogacy, where it's essentially the surrogate's egg and she's being inseminated with the male partner's sperm. So traditional surrogacy we don't do. It's much more complicated legally. So we focus on gestational surrogacy, and I will explain, why the U.S. is a good destination for that. Uh, who needs surrogacy? Basically, there's all different types of people that come to surrogacy. And of course, even within the same category, everybody has their own story. And so we look at, heterosexual couples and same-sex couples and, single men and single women. Uh, Again, we sort of, when we talk about medical aspects of surrogacy, of course, we don't talk about same-sex couples because for them, surrogacy is the only option. And people coming to surrogacy, I'm listing here some of the reasons. There's medical issues. So some women have medical conditions that preclude them from carrying pregnancy safely. So cancer is an example, heart condition, kidney conditions, clotting disorders. There's a long list of things where the woman has eggs, she has viable eggs, she has a normal uterus, but her medical condition doesn't allow her to carry safely. Then there are cases where basically there's some anatomical issue. Of course, someone who's had a hysterectomy where the uterus has been removed, but also cases where the uterus is damaged. Damage can be for different things, and that's actually what I'm going to focus on mostly for this presentation. And then there's, the emotional category of which is real, and people come into surrogacy because they have emotional issue, anxiety about becoming pregnant and carrying a pregnancy. That even a medical term for it, except that I spelled it wrong, but it's called tocophobia. So that's, again, a very legitimate and maybe not so common cause, but we see quite a bit. And then, the category that, we chose to present today are people who basically have a history of infertility. They ended up doing IVF, and then the IVF doesn't work, and then they do it again, and again it doesn't work. And all along, it looks like everything is fine. Embryos look good. Sometimes the uterus actually looks great, and it still doesn't take. So this is for another day, for another talk about same-sex couple and singles. For them, actually, surrogacy is a must. So they need to use an egg donor. They need to use a surrogate. So they come to surrogacy from a different place. Many of the heterosexual couples come to surrogacy after they have failed the more traditional treatments. And therefore, the emotional burden that they carry with them is much more significant than same-sex couples who basically know from the start that that's their only way to have a baby. So again, what we'll focus on today is, cases where, the couple does IVF, whether it's, his sperm, a donor sperm, her sperm, an egg donor, and they do an embryo transfer and it doesn't work. And then they do it again and it doesn't work. And basically at some point you're sitting there scratching your head and said, something has to be wrong. And that's sort of a big point for many couples, is to say, well, we've done IVF, we've tried again and again, and it's not working, and maybe we need to rethink it and maybe try something else. And in some cases, the recommendation, the conclusion is that it's a problem with the uterus, and then you have to basically use a surrogate. And unfortunately, for many couples, this sort of comes a little bit late in the game after they've done many treatments, many cycles. And finally, they come to the conclusion. And then, not surprisingly, because if it's clearly a uterine issue, not surprisingly, surrogacy in those cases is highly successful. But, it's a big step to take for in many different ways. It's an emotional step, a financial step. So, that's why in many cases it's delayed, that decision is delayed. I picked actually two cases from Europe, but those can basically easily be cases that we see here. And those cases sort of just trying to present at least two different angles of failed IVF that led to surrogacy or successful surrogacy. So we have here a couple from Sweden, young couple, married for 3 years, trying to conceive almost from the start. Not successful, and like most couples, had a fertility workup. And they did the normal evaluation, male, female, ovulation, sperm, so forth, and everything looks normal. So again, like many other couples, they started with the more what we consider the first line or more traditional treatments, which is using ovulation drugs and doing inseminations. We usually limit that to 2 or 3 attempts just because we know that if it hasn't worked after 3 attempts, chances of it working if you continue doing the same thing are pretty slim. And that is often the case. They went on to IVF. And not surprising because, she's young and healthy and has good ovarian function and he has normal sperm. The IVF basically resulted in very good embryos. One of the things that was noted, and this was now, again, looking in hindsight, even at their initial treatments, it noted that despite the hormone therapy, the uterine lining was a little bit on the thin side. And as I'm sure many of you know that have been through the treatment, we do ultrasounds to look at the uterus, and one of the measures of the standard ways to look at the uterus is to check the thickness of the lining. And that gives us an idea of how the uterus responds and if it's ready for pregnancy. And as I'll show you in a little bit, of course, that doesn't really tell you always the whole story. And sometimes the uterus is thickening, the lining is thickening, but maybe not really enough or not as much as you would expect. And of course, always, hindsight is always 20/20. So looking back at all these 3 failed IVF attempts, good embryos, and you look back and say, well, maybe there is a little bit of a suspicion here about the lining. The other thing that we sort of need to establish is what is a good embryo. So as I'm sure you know, that when you do IVF, you create the embryos and then you let the embryos develop in the laboratory. We now pretty much always allow the embryos to develop all the way to what's called the blastocyst stage, which is 5 or 6 days. And just that alone allows us to basically differentiate the embryos that are growing well from those that are not. So this is more what we call the morphological assessment. So the embryos that reach the blastocyst stage and look good based on our what we call the grading criteria are considered more viable with a higher chance of success. But we also know that that's usually doesn't tell you the whole story. So the same as with the lining, that you can have a good lining, you can have a good-looking embryo that is not truly viable, in the sense that it's not genetically normal. So it may look good, but if you do a genetic analysis, what we call PGS or PGTA, you find that the embryo basically is not viable. It doesn't really have a chance, and usually will either not take or lead to an early loss. So again, if you have good embryos, and especially if you've had PGS tested embryos, which was not done in this case, then you're even more suspicious that it's really not an embryo factor, but it's a uterine factor. So this couple, the woman, went through an evaluation of the lining. And the evaluation of the lining is something that sort of, I would say, something that's in developing as we speak. We certainly don't have the last word or the final test for that, but there's some new testing that is available now that was not available in the past that allows you to look a little bit more deeply into the development of the uterus, and I will review that a little bit later. But one of them is what we call the endometrial receptivity assay, which is a new test. It's based on the genetics and the gene expression of the endometrium, and allows you to identify what we call the window of implantation. This is the more traditional, historically the more traditional, the endometrial dating, where you take a sample of the uterus lining and you check under the microscope and see if it actually developed the way it's supposed to. Again, this couple, went through this evaluation, and again, normal results. And of course, this is a very difficult situation, both for the couple and for the doctor. For the patient, it's difficult because they kept hearing that everything is normal, yet they're doing all these cycles, and they're not getting pregnant. For the doctor, it's difficult because if everything is normal, if you don't really know what the problem is, then what do you do? What do you recommend? And this is also an issue. So in this case, after many tries and quite a bit of time, finally, their doctor, this is the Swedish couple, recommended at least that they consider surrogacy. One of the issues that we see, especially in most of European countries, Western Europe in particular, where surrogacy is not being done or is not legal. Also, the doctors are a little bit ambivalent or reluctant to recommend surrogacy because they don't really consider that a real option, and that's what, in many cases, delays that decision, or at least that step where the couple needs to consider. So this couple called, and basically we reviewed the history together, and I agreed. I thought that they've given it a really good chance with their own IVF, and I thought that surrogacy was a good idea, and I thought that surrogacy would give them a really good chance, mostly because everything else was okay. So that's what they did. So they found a surrogate, a 42-year-old. I'll focus on that in a little bit, because even though the parent was in her early 30s, the surrogate was in her 40s, still we thought that she was a really good candidate. The surrogate was healthy, has 2 children, 2 normal pregnancies, normal delivery. So we got the surrogate all set, screened, tested, and ready. And then we went and created embryos. So the couple did IVF. They did do the PGS testing, and that's something that I highly recommend. I'm a big believer in doing this test, even in young women, even in egg donors, but because we find that surprisingly a high percentage of the embryos are genetically abnormal. And then we did a single embryo transfer, which is, again, something that we do pretty much routinely now. So the surrogate was prepped for the transfer. With the surrogates, we often actually use what we call a natural cycle protocol, where we rely on her own cycle to prepare the uterus, because these women have normal cycles, conceive naturally, have their own children. And then we do the transfer. And the transfer here, unfortunately, didn't work on the first attempt, but was successful on the second attempt. Pregnancy was good and delivery was good. So, of course, you can imagine that after the first failed attempt, we had a little bit of a crisis, because they said, well, we tried everything else and then we did surrogacy, it didn't work. But you have to keep in mind that even under the best circumstances, good embryo, PGS tested, good surrogates, we're talking about somewhere in the neighborhood of 70 to 80% success with IVF. So in most cases, if it doesn't work the first time, it works the second time. So the success actually with what we call the cumulative success between the first and second cycle is over 90%. So most people are successful on the first try, and of course those that are not often are successful on the second. Just to mention, of course, the big part of surrogacy, in addition to just the whole pregnancy, is the legal fact, the legal aspect. That's really, really important, and it has to be handled really, really carefully. And of course, being from Europe adds another level of complexity because, once the baby's born, they want to go back home and they want to make sure that the baby actually is registered in their home country and has all the necessary papers. So what we do in the U.S. Is basically there is a contract that you would be signing with the surrogate, a legal contract that covers all the different aspects of the process before, during, and after. The contract pretty much covers everything. It's pretty long and detailed, and of course, it's something that you would work together with the surrogate and come to an agreement as far as the cost, as far as what you expect her to do or not to do during the pregnancy. How many embryos she would transfer. And nowadays, with COVID, of course, being on everyone's mind about what she would do to basically stay safe during COVID. So the surrogacy contract is basically done as prior to scheduling the embryo transfer. As soon as that's done, we can move forward with the transfer. And then she becomes pregnant. And one of the things that we do in the US, which when it first was introduced was sort of a breakthrough, is the fact that we can actually register the parents during the pregnancy as the legal parents. So the lawyer would go to court, and the court will basically declare you as the parents, which means that as soon as the baby is born, both of the parents' names are on the birth certificate. And that's, it may not sound like a big deal, but it is, because it simplifies the whole process. And also, it's something that can be done for same-sex couples as well. And again, makes it easy. Another thing is that the baby, of course, when the baby is born in the U.S., by American law, it becomes a citizen. Maybe being an American citizen used to be a big deal, maybe not so much anymore, but still the baby immediately becomes a citizen and within a few days can actually get a passport. And then it's just a matter of where you are in the world and what your local laws are. And sometimes it's possible or easier to actually get your baby the local paperwork or citizenship here in the consulate, or what most people do is actually travel back home with their American passport with a visa, and then make all the arrangements with a local lawyer in their country. So this is what this couple did. So this is a case, of course. Thankfully, we had a happy ending, and they had a baby. They are planning to come back to have another one because they have more embryos. But it took them quite a while, actually a number of years, to actually reach that point where they decided that surrogacy was the right option. Very quickly, another example. This is a couple, it's a little bit different. This is a couple from Germany, also in their 30s. They had a child. They have one child, basically no problems, got pregnant easily, normal pregnancy. And then the delivery was a little bit complicated. She suffered a hemorrhage, and things sort of got a little hairy there because she had a lot of bleeding, and then she required a D&C. That part of the placenta was left behind. And that's usually sort of concerning because in this process, when this happens, you can damage the uterus. The uterus can get damaged and not really fully recover. So she tried again, after the baby was born. They waited a little while and then tried again. We're not successful this time. They waited 2 years. Finally went to see a doctor, and then they did the evaluation, and they did find in this case, not surprisingly, that after all the trauma that the uterus has been through, that she had scarring of the endometrium. It's a condition that's called Asherman syndrome. And that's something that's sort of difficult to treat. Because the uterus actually has an amazing ability to regenerate, but not if you damage the entire thickness of the lining. And this is what happened here. So she had a procedure, which I'll show you some examples of. She had a procedure called a hysteroscopy, where you look inside with a scope. You remove the scar tissue, but often, unfortunately, it does come back. So she had this procedure. She tried IUI. They're trying to sort of going through the steps, and then did IVF. And then the IVF was actually, and it was successful in the sense they got a bunch of embryos. The embryos looked good, but never really got the uterus to respond to hormones. So when you do IVF, you, of course, the hormone stimulation and should create a good lining, a receptive lining. And if you give hormones, and especially if you give a high dose of hormone and the uterus doesn't develop well, then that sort of immediately raises a red flag. So they did. I mean, this is back in Germany. They had a bunch of attempts actually with these blastocysts, and it didn't work. And again, finally, after a number of attempts, they still had embryos left. And they decided to explore surrogacy. We spoke to them. I agreed based on the evaluation. In this case, actually, we did get the embryos from Germany. We found a surrogate, 40-year-old from Connecticut. She had her screening, accepted, and had a single embryo transfer and became pregnant on the first attempt. And again, it's great. It's wonderful. Not entirely surprising, because if you remember the history, this woman had her own pregnancy with no problems, and then had trouble mostly because of the uterus. So she had good eggs, there was good sperm, but the uterus was a problem. And it's sort of the same thing. The contract, the pre-birth order, the parents were listed, the American passport, and they again traveled back home with the American passport. So basically, these cases are just sort of to demonstrate this particular area in which surrogacy is helpful after failed IVF. And what we saw here basically is one example of mechanical damage. This was actually, in this case, with surgery. The woman had a D&C after having a postpartum hemorrhage, bleeding. And that's probably what we see more often. And then there are some cases where you can actually find an abnormality that's more of a functional abnormality with some of the older tests or some of the newer tests. And then these people where we don't know, we just basically, it's sort of a process of elimination. We say, well, we've done IVF, everything's normal, embryos look good, uterus look good, we've done it a number of times. It probably is the uterus. So sometimes you can tell, sometimes you say, okay, we know the problem, this is the solution. And sometimes you take sort of, it's almost like a leap of faith to say, we've tried everything else, and let's try surrogacy. So how do you know? I mean, sometimes, like I said, there's a history, D&C, bleeding after delivery, and infection. Sometimes you find it on the testing, on the more standard testing, like the ultrasound or the X-ray. And then there are some basically new tests that allow us to get a better idea of the endometrium. So as I said, looking at a structural defect, usually the ultrasound and the hysteroscopy are very good tools. The hysteroscopy is where you take a direct look at the uterus and you can find scar tissue, or you can find things that may be in the way. And again, sometimes you can treat it and it works. Often, if the uterus is really damaged, it doesn't work. And then there's the more subtle things, I would say, because they're not always so obvious. So we have basically what we call the functional assessment of the uterus. So for example, as I said before, and again, I'll show you in a minute how that works, but there is a test that allows us to determine whether the embryos are actually placed at the right time of the cycle into the uterus. And then there is a category of there's an infection. It's called endometritis. And it could be a very, very subtle infection that can be only diagnosed by actually looking at the tissue. And of course, the functional assessment is if you give hormones and the uterus doesn't respond, then you basically know that there's something functionally wrong, even though we may not have the right tools to identify it. And of course, in many areas in medicine, there's always what we call the idiopathic or the unknown. Everything's looking great, and you try again, and you try, and you try, and it doesn't work. So just a few examples here of basically what these tests look like. So an example of this is a vaginal ultrasound. And if you can see here, on the left side, you see the uterus. And in the middle, with those two little dots, is the lining. So this lining looks great. It's beautiful. It looks fluffy, thick, looks normal. Here on the right side, you can see the uterine lining actually looking very thin. And of course, it makes sense, and it's true that this lining doesn't have what it takes to hold a pregnancy and to hold on to a pregnancy. So of course, if I mean, that's sort of an easy diagnosis, because if somebody takes medication and has a thin lining, you say, well, something is wrong. Again, this is the other case we discussed, is where there is some scarring of the uterus, and the scarring actually comes inside of the lining. This is what's called a hysteroscopy, where you take a look with a scope, and instead of seeing, I should have put a normal picture here for comparison, but all this white stuff and all these strands of tissue are scarring. They're not normal tissue. And they're basically an indication that the uterus, the lining of the uterus, the layers that actually produce the tissue that supports the baby, have been damaged. So these are the more sort of historically the standard or the common diagnostic tests. Endometritis, the infection, again, has a typical appearance on hysteroscopy, but not always. So you see those tiny little frongs here. This is sort of an indication of an inflamed or infected uterus. But we know now that we have more sophisticated tests that you can actually have endometritis and have a completely normal uterus. So you can do an ultrasound and you can do a hysteroscopy and everything looks normal. But if you take a sample of tissue, you can find that there is a problem. So back to the test of the implantation window, what we call. And this is sort of a concept that's, I mean, we've known of the implantation window of course, for many, many years, but didn't really have a good tool to evaluate it. So if you look at the uterine lining during the cycle, right, from the beginning of the cycle to the end, there are two stages of the development. what we call the proliferative phase. That's the early stage of the development, with the uterus is under the influence of estrogen, and that's when the uterus thickens. That's the response to the estrogen. And then as soon as the ovulation occurs, basically the uterus goes into what's called the secretory phase, or the luteal phase, where actually it doesn't thicken much anymore, but it becomes more dense, and the content of the cells changes and basically becomes more supportive of the pregnancy. So, and this basically continues all the way to the end of the cycle until the period, and then starts over again. Now, during this entire cycle, there's a very narrow window where the uterus is actually receptive to pregnancy. So if you look at the uterine lining, and most of the time, it would not allow an embryo to attach. So the window, that's what's called the window of implantation. It's usually about 48 hours. And when we do IVF, and when we put the embryo into the uterus, we basically assume that we're putting it in during the right time. And this is based on experience with many people. You have an embryo that's 5 days old. You take basically 5 days after ovulation, or after you start taking progesterone, and you say this should be the right time. Now, interestingly, with the more sophisticated test that we have, we find that this is not always the case. So this here, what you see here is basically the cycle. There is what's called the pre-receptive phase and the post-receptive phase. In other words, the uterus is not receptive before or after this implantation window. And what we can do now is we can basically take a sample of the lining, and where we assume it's the right time to put the embryo in, and see if we're right, see if we calculate correctly. And this is what you expect to get. So that's what it looks like, and this is where you are. But what we sometimes get is that, you're here or you're here. In other words, we did it at the time we thought was the right time, but actually for your particular case, for your uterus, it was not the right time. So that's something that usually we can work with, and we can actually adjust the timing of the transfer. So, okay, well, we maybe need to put the embryo in a couple of days earlier. So when we find something like this, of course, I always feel good, because I say, okay, we have something we can work with. And very often, if you just make the adjustments, you can actually make it work. If you have somebody that has endometritis, unless the damage has been really, really severe, you can treat with antibiotics, and you can make it work. With uterine scarring, with Asherman syndrome, like I said, the prognosis, the outlook is not always great. So you can try and treat it, sometimes surgically, sometimes with hormones. But very often, if the damage is too severe, it doesn't work. Basically, for the way the IVF, I just want to give you sort of a quick diagram, a quick overview of how the IVF cycle is done when you're using a surrogate. And we always do it in two parts. So we always create the embryos first. We create the embryos, we grow them, we test them, and we freeze them. So this is the first part of the cycle. And again, this could be the female partner, or it could be an egg donor. The treatment is a standard IVF treatment, usually 2 weeks of medications, harvesting the egg, we call the egg retrieval, fertilizing the eggs with the sperm, making embryos, growing them all the way to day 5 or 6. And then we do the genetic testing, and we freeze them. So that's usually the first step. We can usually start that immediately. And within 1 month, we know exactly what we have. In other words, how many good embryos we have. So the genetic testing will tell us that the embryos have the right number of chromosomes, and therefore they're viable. And then while this is happening, we look for the surrogate. We put her through the evaluation, the screening, the testing. And once she's confirmed and we have the contract, we basically start getting her ready. Like I said, usually with a natural cycle, with a little bit of medication, usually takes about 3 weeks from the time she starts her cycle until she's ready to have the embryo transfer. So this is the surrogate. This is what we call the frozen embryo transfer. And we usually transfer a single embryo and get about 70 to 80% success with a PGS normal embryo. We occasionally, not often, do 2 embryos. It has to be the right situation. For regular IVF couples, we usually don't do 2 embryos, but for surrogates, I think the risk is less. So it's something we can certainly discuss. So this is basically the whole story. This is how the whole thing is done. A few words about surrogacy in the U.S. I've had experience working with surrogacy in different countries, in Asia and Eastern Europe. And the U.S. has many advantages. I mean, the advantage is, first of all, the process is completely legal in most states. As I said, you can do a contract. The contract holds up in court. You can do the pre-birth order, and you can register the baby in the birth certificate as your own baby. Also, working with surrogates in different countries, what I've noticed, what I've observed, that the surrogates, the American surrogates, are generally have a higher standard of living, are healthier, and which is really, really important because they're carrying, your baby. So you want to make sure that everything is good on their end. And then finally, the process of IVF is highly successful, more so than it is in other countries. The technology, the fact that we do PGS, I think contributes to that. The surrogacy process in the US requires that you work with a clinic, with a fertility clinic, and also with a surrogacy agency. So when you're ready to do the surrogacy, we would connect you to a surrogacy agency, and the surrogacy agency will help you find your surrogate. They will talk to you, they'll ask you a million questions and try to find someone who is a good match for you based on many different criteria. From the medical perspective, from the medical side, we're looking for women basically who are healthy. But essentially the criteria, the requirement to become a surrogate is that you have to have children. And from many reasons, but from the medical side is the fact that we can actually review their pregnancies, review their deliveries, make sure that there's no issues. I always get the surrogate's doctor involved. In other words, making sure that they approve of her being a surrogate because they know her better. So as soon as the agency finds a surrogate, they will send me her medical records to review. So this is in the fertility clinic column. And the surrogates, basically, once the medical records are reviewed, we will invite the surrogate to the clinic. We'll meet with her. We finalize her testing. And we introduce her, in most cases, at that point to the parents, either in person or remotely with a video call. And as I said before, I showed you that the surrogate, one was 40, one was 42. I mean, we sort of like the surrogates to be between 30 and 40, but actually, in my experience, that's really not that important. We have younger surrogates and older surrogates, they're doing just fine. We, of course, make sure that they're healthy. We like to make sure that their BMI, the body weight, the weight is within the normal range. But again, you have to look a little bit beyond the weight and just see how their health is and how their pregnancy was. So even if the surrogate is somewhat overweight, but had perfectly normal pregnancies with no complications, she may still be a good candidate. So what I've listed here in these 2 columns is what the agency does and what the clinic does. So the agency will find the surrogate, we screen her, make sure that she's good. send you back to the agency to do the legal arrangement, and then we do the embryo transfer. So we create the embryos and do the embryo transfer. The agency will continue, of course, following you on the legal end. They will help you with the insurance for the surrogate. They will help with arranging payment for the surrogate. All these things are really, really important, and having a good, reliable agency is critical. We work very closely with the agency, and actually I look at it as being sort of a team. So we all work together to make the process simple and successful. So people who come to us, we will connect you with an agency that we think is a good match for you. There's many, many different agencies in the US. Some are good, some are not so good. So I can tell you, my experience and my recommendation. And I already covered this, but essentially, of course, the surrogate has to be healthy, physically healthy, mentally healthy. And we spend a lot of time on the psychological evaluation. And then number one condition is she has to have children. And then when we bring the surrogate in, basically we do a medical evaluation, we do a psychological evaluation. We spend, like I said, quite a bit of time on that to make sure that she fully understands what that means for her to carry for a baby for somebody else, what it means for her, what it means for her family, and of course make sure that the match, that you and the surrogate are on the same page. And of course, goes without saying that we do infectious disease testing as well. And I can't end this without sort of saying how important I think that the emotional part of this process is, and how important is that when you do it, you have complete trust in the team. And the team is the clinic and the agency and the surrogate and everyone involved in the process. The lawyers, the psychologists, the accountants, everybody that's involved. And for that reason, I do believe that what we have in the U.S. is a safe and very effective way of doing surrogacy. So I'm going to end here. I have a sort of a quick summary because I see there's a few questions. I'll have a few minutes to answer. So essentially, that what I was trying to convey is that the surrogacy is a highly successful solution for some cases of IVF failure. So of course, you need to be careful that you've looked at everything else and essentially pointed to the uterus to say, okay, this is the reason. So we have what we call a uterine factor. So IVF failures, especially repeat IVF failures, in the presence of good embryos, again, I explain what that means, is very suggestive that there is a uterine factor. And with the new tests that we have, sometimes you can actually make a diagnosis and sometimes you can treat the condition, the uterine factor, and then maybe not need to resort to surrogacy. So I think we have more tools now than we ever had to try and identify the issue, the problem. And then finally is the fact that, as I said, the IVF in the US is safe and legal and very successful. So thank you, and I see that we have a few questions.
And wonderful. Thank you so much, Dr. Lavy, for that presentation. Lots of useful information, and of course, as always, lots of details. Thank you for that. And yes, you are very right. It is time to start with our Q&A session. So the first question is ready as well. Okay, so just let me remind everyone that if you would like to ask, just go ahead and type the questions in the chat section. And the very first question is right here. How long before the embryo transfer should the surrogate mother take her prenatal vitamins? Which organic prenatals are the best in your view, with folate rather than folic acid?
So, of course, as part of the preparation for the surrogate, we basically review her her medical history, her health history, her diet. And of course, we recommend prenatal vitamins. So as soon as we introduce ourselves to the surrogate, we make sure that she goes on the prenatal vitamins. And the reality is that actually, if the woman is healthy, doesn't have any medical issues, and has a balanced diet, the need for supplements is questionable, but we always do it. Of course, once you get pregnant, you have to take the prenatal vitamins because your body requirements increase. So, this is an ongoing debate whether organics are better, or I personally don't think it makes much of a difference. I think you just have to get whatever vitamins you have to get from a reliable manufacturer. There's really no difference, in my opinion, between folate and folic acid. And again, mostly because folic acid is a water-soluble vitamin, and it doesn't really stay much in your system. You want to make sure that the person actually their diet is good, balanced, and that they take prenatal that usually has enough folic acid. I actually like to add a little bit extra folic acid to what's already in the prenatal vitamins, just basically for good measure, and just because it does help prevent certain birth defects.
All right. Perfect. Thank you so much for that very first question, and of course for explaining. But actually, there is a follow-up, okay, from Angela. So let me go to that question straight away. So what sort of tests are done during the pregnancy, and how long should they be on prenatal vitamins? What should they not be taking in terms of vitamins or medication?
Well, again, I mean, I think the most important is that they have a good balanced diet. I think taking prenatal vitamins, especially with the newer preparations that have DHA is enough. I think sometimes you're right that sometimes people tend to overdo it with their vitamins, and we definitely discourage that. So just basically one of the prenatal vitamins. I mean, we usually use ones that are prescription. And I think that's a very complete, for a healthy person, it's very complete, and you don't really need anything else. How long should they be on it? Most of these vitamins, as I said, don't really get stored long-term in your body, and they need to be taken on a regular basis, which also means that it doesn't take very long for even people who are deficient to get to normal levels.
And wonderful. Once again, thank you. One more follow-up. Okay, so let's have a look.
Yeah.
Can you give the name of the prenatals?
Oh my God, I have to look. No, I can't off the top of my head. I mean, we use certain brands, but I can certainly send you.
All right, understood, of course. Thank you so much. Remember that you can always use the link. I will send it in a minute. And of course, you can get in touch with Dr. Lavy. I'm sure he'll be more than happy to help you out as well. Okay. Thank you so much for your question. And let's have a look at the next one right here. What if some unexpected medical complications happen when the surrogate is pregnant? Is there any guarantee?
That's a good question. I mean, the pregnancy is a pregnancy. I mean, it's not a disease, but it's something that, carries risk. So again, one of the reasons, again, to pick women who have children is to try to mitigate, to reduce that risk as much as possible. So somebody who's had basically normal, uncomplicated pregnancies, normal deliveries, their chance of having any complications is much, much less than someone who conceives for the first time. So that's sort of just going into the process and picking the surrogate. Now, on the embryo side, as I said, doing PGS for me is a big advantage because it allows you to basically select the embryos that are more viable, that have a better chance of being successful. So, for example, the risk of having a pregnancy loss, a miscarriage, is much, much reduced by picking, PGS normal embryos. But of course, things can happen. There are certain defects, right? That the developmental defects that the baby can have that are not genetic, that we cannot test for, things that develop during the pregnancy. And then there's things that can happen to the surrogate. She can develop hypertension and diabetes and preeclampsia and all those other things that can happen in pregnancy. Again, much less likely for someone who has a good history. So the answer to the question is that there's no way to be 100% sure that everything will go well. So all we can do is basically prepare, and we do our best to make sure we've covered all the different aspects and lower the risk as much as possible. As far as a guarantee, I mean, that's, it's a difficult thing to do because you can't guarantee for sure that the pregnancy will be okay. But there are ways, I mean, if you're going through this process, there are ways that you can basically plan or sign up for what we call a baby guarantee. In other words, that you continue trying with a surrogate until there is a baby. It's more like an insurance policy. We can be done. It's more expensive. We definitely offer that package, and certainly we can talk to you about that.
Understood perfectly. Thank you so much for clarification to this question as well. And I have just sent you the link. So, of course, if you would like to get in touch with Dr. Lavy, you can use it. And there is an option to ask your questions, and it will be directed to Dr. Lavy and his team, of course. And we will be slowly finishing. There are like 2 questions left. So, if you have any more of those, just go ahead and type those in right now. And, well, let's have a look at the next very interesting question as well. Is surrogacy possible with an embryo donation, or either own egg or own sperm must be involved?
No, certainly not in the U.S. So there are certain countries that require that you have some genetic connection to the baby. But yeah, but in the U.S. it's not necessary, it's not required. So it really depends on the laws in your own country. So we often do surrogacy with donor eggs. We often do surrogacy with donor sperm, and we sometimes do surrogacy with both. So there's someone basically, for example, a woman who is a little bit older, who basically doesn't have eggs or doesn't have good eggs, it needs an egg donor, it doesn't have a partner. That person can use an egg donor, a sperm donor, and a surrogate. And again, the process in the U.S. is very transparent, very legal that way, and you just have to check in your own country if that's something that is allowed.
And thank you so much for that clarification. Thank you for mentioning that, because I know that in some countries there has to be like a link, yes, to the
Genetic connection.
exactly. So that's good to know. There's another reason for why here in the US it's a bit easier then. Yes, thank you so much for that. And let's give it a minute. Okay, I do not see any more questions, but of course, let's see if we have all the if we answered all of your questions. Okay, yeah, just one right here. Okay, about your opinion, why do you think surrogacy is still illegal in some countries, and do you think it might change?
Yeah, that's probably that's a really really good question, and I don't really have a simple answer for that because you can see for example in Europe. Um, so there are certain countries where surrogacy is legal. Eastern Europe, Russia, Georgia, Ukraine. Uh, but it's only legal for heterosexual married couples. Then there's other countries where it's illegal, and those countries are very different. I mean, you can look in Scandinavia, for example, where it's illegal, and you can say, well, this is a very progressive country. Maybe there the reasons are more have to do with fear of exploiting women. And I think that's probably what is the motivation behind it. And then there's countries like Spain and Italy and France where it's probably more has to do with either cultural or religious or other reasons. Um, so I think it's different in different countries. I think, even in the US, actually, surrogacy is legal in only some states and not legal in others. Some of it is religious, some of it is political. So I think in every case is different. And unfortunately, the trend, and again, in my experience working, I worked in India and in Thailand and in Nepal and in Georgia and Ukraine. Actually, unfortunately, strangely, things are actually going the wrong way in most places. Because, for example, people used to travel to India to do surrogacy because it was easy and not very expensive, and that closed down. And then the same thing happened in Thailand, and then the same thing happened in Nepal, which were sort of big surrogacy destinations. So yeah, I don't know how to answer that. Is it going to change in the near future? I hope so. I think mostly in the U.S. it's changed because of grassroots movements and pressure, but I don't know.
Yes, we just need to wait and see, I guess. But thank you so much for that question. Definitely interesting, but as you said, it's very hard to give a yes or no question. Sorry, answer, of course. All right, excellent. Thank you so much for that. And at least now I do not see any more questions, so we will be finishing. But of course, don't forget that if you would like to get in touch with Dr. Lavy and his team, you can just use the link I have just sent to you, and I'm sure he'll be more than happy to help you out as well. So, Dr. Lavy, thank you so much for today. Definitely lots of useful details here. So, as always, it's been a pleasure to have you back with us, and I don't think it's our last one. So, I'm very happy and excited to have more of those events coming up. So, thank you. And thank you everyone for joining us, for your questions, and I believe it has been useful to you, and of course best of luck to all of you. And well, Dr. Levy, is there anything you would like to add?
Just thank you for having me, and thank you everyone for attending. And as I said, I know this is a highly emotional, very difficult decision to make, and I think the first step is to basically become more informed and get all the information that you need. So I'm available. I'm more than happy. You can write me. More than happy to arrange for a call. And
All
again,
right.
thank you for being here.
Excellent. Thank you so much as well. And of course, there is one thank you here for you as well from the patient. And of course, remember this has been recorded. So if anyone missed any parts, then of course you will be able to watch this. It will be available tomorrow. It will be uploaded on our YouTube channel, but also on my IVF Answers. You will be able to find it there. So don't miss it. And of course, I hope to see you tomorrow at 8 p.m. UK time again. And well, Dr. Lavy, thank you so much. I know you have a busy schedule, so thank you for your time. And of course, have a lovely day and evening wherever you are, all of you. And well, this is it for today. Thank you. Take care.
All right. Bye bye. Bye bye.
Bye.